Good afternoon, ladies and lunatics. My name's Danny. Welcome to the first episode of the My Own Worst Enemy podcast, where it's my job to explore the world of mental health and well-being with the aim of providing you guys with information and advice that you can apply to improving your own mental health and well-being. On today's episode, we're going to be exploring the topic of depression, which I know on the face of it might sound like a pretty straightforward endeavour, but once you scratch the surface, you'll actually find that sitting below there is a rabbit hole so deep, there's really no way we could squeeze in any kind of comprehensive analysis in the space of 60 minutes. So instead, what I thought we'd do is something more akin to a brief introduction, which we could then kind of use as a springboard to further discussions down the road. So my guest today is Professor Chris Dowrick. Chris is the Professor of Primary Medical Care at the Institute of Psychology, Health and Society at the University of Liverpool. He's a general practitioner with Aintree Park Group Practice. He's an honorary consultant in primary care for Liverpool Primary Care Trust and a non-executive director for Merseycare NHS Trust. He's a member of the NICE Guideline Development Group for Depression and Chronic Physical Disease, NICE being the acronym for the National Institute for Health and Care Excellence, in case you were wondering. He's also Editor-in-Chief at the international journal Chronic Illness, and he's the author of the book Beyond Depression, A New Approach to Understanding and Management, the contents of which forms the basis of the following conversation. So whenever you hear me referring to his book and the information contained within it, this is the book I'm speaking about. So the main reason I thought Chris was the perfect person to get us started on the topic of depression is that, well, he works on both sides of the divide, if you like. He's a researcher and academic, but he's also a family doctor. So, you know, not only has he got the abstract knowledge of depression as a clinical interest, but he also has knowledge of how the results of, say, clinical research plays out at a primary care level, where the rubber meets the road, if you like. And also in dealing with people suffering with depression outside of the confines of clinical studies and out there in the real world. So despite us merely scratching the surface during the course of this conversation, that didn't stop us covering some pretty interesting ground. And I think there'll be plenty of information in here that you wouldn't necessarily expect to find in your kind of average introduction to the subject of depression. So we talk about things like genetic factors, evolutionary theories of depression, the influence of the pharmaceutical industry, whether or not doctors are guilty of ignorance when it comes to mental health. We even talk about the concept of iatrogenesis, which, if you're not familiar with, will definitely leave you with something to think about, particularly with regards your own experience with mental health problems. As I say, these are all things I plan on delving into much deeper at some point in the future. But there's certainly enough here to get us started. So if you're interested in seeking Chris out on the interwebs, he has a blog where he posts articles offering advice on healthy ways of thinking and being. That's at www.wellbecoming.blogspot.co.uk. You can also find him on Twitter at CFD1951. That's at CFD1951. And a quick note before we dive in, early in the discussion you'll hear us referring to the DSM and the ICD. Now, if you don't know what these publications are, the DSM is the Diagnostic and Statistical Manual of Mental Disorders, which is used by mental health professionals primarily in America to categorize and diagnose mental health disorders. And the ICD, that stands for the International Classification of Diseases. That's published by the World Health Organization, and chapter 5 of which is something similar to the DSM, but is what tends to be used over here in like the UK and Europe. So there you go, everything you need to know. So without further ado, here's my conversation with Professor Chris Dowrick. Okay, Chris Dowrick, welcome to the podcast.
Thank you very much.
We're here today to talk about depression. In doing some of the research for this interview, one of the things I was having trouble with was actually finding a definition of depression to come to you with to actually talk about. And if I'm being completely honest, I didn't find one I didn't find any kind of general consensus, if you like. So what's your opinion on that? What would you say is a general consensus definition of depression, if there is one?
Well, I think it's a very good place to start, because I think there actually isn't a general consensus. If you look at sort of the population as a whole in this country, or certainly the population as a whole worldwide, I mean, there are consensuses of sorts within the healthcare profession, and so a number of patient groups will sign up to those as well. So I mean, if you look in psychiatric textbooks, or if you look at the International Classification of Diseases or the American Diagnostic and Statistical Manual, they will give you a very clear set of symptoms and signs and criteria that you should use to make a diagnosis of depression, and to make a diagnosis of whether it's mild or moderate or severe, or whether it's bipolar or unipolar. So within healthcare, there are definitions which are generally accepted. But do you think there's one which, say, in the UK maybe, or in Europe or America, that's, because my understanding is that in Europe and the UK we tend to go off the ICD, and where America tends to go for the DSM. That's broadly so. Yeah. So there isn't very much difference between them. I mean, there are some differences. I mean, the DSM has sort of two key questions to do with mood and pleasure, or lack of pleasure, and then a set of eight other questions, and depending on where you stand on those, you either have a diagnosis of mild or moderate or severe depression. Whereas the ICD is a little bit broader. It tends to have 3 or 4 main ones, and then another cluster. But they're broadly comparable, and they're actually becoming more comparable. But that's not least because the American pharmaceutical industry and others are actually doing a lot of the funding for WHO to produce its next set of guidelines, so ICD-11. So that there is actually, for various reasons, there's more of a convergence of those sort of diagnostic criteria. Right.
Okay. So, I mean, that sounds troubling. If I'm honest, if we were talking about something like cancer, for instance, there's very clear parameters there of what constitutes cancer.
Yes.
But when it comes to depression, it's very subjective. Is that fair to say?
Well,
because the mental health support group that I run, you'll hear people say a lot that depression's tricky because it shows up in different ways in different people. People experience it in different ways. So, I mean, the immediate reaction to that then is that, well, depression isn't really a thing in and of itself. It could be a broad range of things. But I know you write about this. Depression is a unitary concept.
Yes,
and that you're not a fan of that idea.
No, well, it's out there. I mean, it's a common idea, and it's an established idea. But I think it's an idea that needs to be discussed and debated. I see that as actually a contested idea.
What's the origin of it? Because the strange kind of paradox, if you like, is that it seems to be generally accepted that depression is different for different people, has different symptoms, etc. But at the same time, it's also accepted that depression is a thing. It's this one thing that you can categorise. Where's that idea come from?
Yes, I mean, you put your finger on a very important point as to whether depression is a thing, or whether it's a lot of different things, or whether it's not things at all. It's just different experiences that are presented in those ways. I mean, where its thingness comes from, I think, really is if you look back over the last 30, 40 years, it comes from essentially, I think, from a group in the States who were trying to develop some effective research into common mental health problems, and they produced some research criteria for understanding a concept called depression. And those research criteria are actually morphed into DSM-3, and then DSM-3R, and then DSM-4 and DSM-5. So it comes from there. I think it also comes from a desire, particularly in the psychiatric profession, to develop itself as a unitary discipline, and therefore to bring together, for them to have a unitary discipline. It's easier if you've got unitary diagnoses that you can work to.
Okay, because it calls not having those specific diagnoses calls well, it calls the entire endeavour into question, I guess.
Yes.
The legitimacy of it, at least.
Yes, I think that's a fair way of putting it. Yes, I mean, for me, feeling very low, feeling suicidal, feeling that you've got no energy, that life is just awful, those are absolutely real things. Yeah. And I get them myself to a mild degree from time to time, and they're just awful. Yeah. So what I'm saying is not to deny the reality or the legitimacy of those experiences that people have, but I do have concerns about lumping them all together into a unitary diagnosis.
Yeah, and the way you've articulated that in your book is as border disputes. Yeah. Which there are 3. Yeah. If you'd like to.
Okay, if I can remember them, I will do that. Yes, yeah. So I mean, there's certainly disputes. I mean, some people think that the diagnosis of depression is too big. And,
so are these so we've got, just to remind you.
Thank you. Good. Please do, Danny. Thank you. Yes.
Yeah, we've got anti-imperialist, yes, integrationist, yes, and then fundamentalist. Yes. So if we start with the anti-imperialists, who are they? They're
the ones who think that the diagnosis of depression is actually taking over the world. Is just becoming the thing that, whether it's mental health or in public health, is the thing that everybody has and needs treating for. And they would be, some of them would be psychiatrists, some of them would be family doctors, some of them would be sociologists or anthropologists who would say, look, this is just a bit silly, to try and lump huge numbers of human experiences into one thing.
So have we got any examples of what might be lumped in that would kind of be considered a bit ridiculous, like going too far?
No, it's not. Well, I think it gets to the heart of it very quickly. If you do community surveys of the population in general, you find and it relates to deprivation, which we'll probably come back to later on. You find in the UK, for example, that probably about a quarter of the population at any one time have got symptoms that are consistent with something to do with depression or anxiety or a mixture of the two. Whereas if you're in sort of the favelas of Rio, then probably 90% of people have those. So if people will therefore jump to conclusions that all of those people are suffering from mental disorder.
Right. Okay. Yeah. So integrationists.
Yes.
Integrationists
are people who think that you should have broader categorizations, and I mean, I've got quite a lot of sympathy with this particular view. That certainly, if you look at, as I mentioned earlier, if you look at depression as a thing, if you accept that for a moment, and anxiety as a thing, if you accept that for a moment, actually those two things occur very, very much more commonly together than they do either on their own. So that there'll be a lot to be said for having a broader diagnostic grouping of sort of a mixed affective disorder, which has the rather unfortunate acronym of MAD, which we need to keep away from. But actually, I mean, that's, if certainly in primary care settings, most people who I see who have got symptoms that fit with a diagnosis of depression also have symptoms that fit with a diagnosis of anxiety. It's quite unusual to have just one or the other.
Yeah, well, that was my personal experience of it. Was is it called comorbidity?
Yeah, well, it is, but the trouble with that term is that comorbidity implies there are two different things. One of which is comorbid with the other one. So yes, and then people talk about comorbidity of depression with diabetes or depression with alcohol or whatever. So you're absolutely right. It's called that, but that's buying into the sort of the unitary diagnostic.
Wow, okay, yeah, interesting. Yeah.
So but I mean, there are other people, in psychiatry and elsewhere who say, well, actually, it's much more sensible to have these broader diagnostic groups. Yeah, and so
finally, the fundamentalists, which I believe you subscribe to.
I probably do. I'm always a bit cautious about, but if I have to sort of pin my colours to a particular mask, I probably do. Yeah. Because the fundamentalists would say that, yes, there are some people who absolutely categorically do have a discrete condition which has the characteristics of, we're talking about with depression, the sort of suicidal ideas, just lack of energy, just life being awful and whatever, which may have some biological or genetic origins, and which isn't necessarily related to life circumstances. But that would be, as it's currently constituted, that would be a rather small subset within the much broader grouping of people who are given a diagnosis of depression at the moment.
Okay. So to kind of close this segment, if you like,
fine.
To get us started, because what we're searching for here was a definition of depression that we can kind of move forward with. Taking all that into consideration, what would your definition of depression be? If you could take over the Wikipedia page of depression and write the introduction for it to tell people what it was, what would you? Well,
I would want to turn it. I would want to turn it not into a noun, but some adjectives or some adverbs probably, because with the proviso I've just said that I think there may be a small group of people for whom a noun might apply, who do have very specific symptoms and with a very specific background. I think most people are in a situation where they are feeling depressed.
Yeah.
So the word depressed, I think, is more important. They're feeling depressed because of lots of things that have gone on or are going on or might go on. Or even better, I think in some ways, the people are finding life depressing. So if I was writing the Wikipedia, I would start with those two words, depressing and depressed, and then I would put depression in rather small type
because it's such a subjective experience. Do you think that it's almost the patient, if you like, the person who's suffering gets to define it for themselves, if you like?
Well, I think that gets really complicated. I mean, yes, but obviously people will only define depression for themselves if they've heard the concept before.
Okay.
And so where do you hear it from? You hear it from the media. You hear it from from a mental health professional or a GP that you may have been in touch with. But if you're a member of an Aboriginal community in Central Australia, or a member of many different communities in this country or elsewhere from an Islamic background or from a Hindu background, you're actually much less likely to come to that sort of view, because it doesn't fit within your understanding of how the world operates and how you fit within it.
Well, I mean, that's for me. I mean, that's still an interesting conclusion to come to, is that there really isn't one, is there?
Well, no,
there just isn't.
With a very small footnote that there might just be a little bit of one for some people. I don't think there is, and I think it's something that it's maybe helpful for some people, but I think for a lot of people it actually isn't very helpful at all. It's actually getting in the way of useful understandings of how they are and where they're coming from, and importantly what they might do about it.
Okay, so I'd like to move on to some of the causes of depression, or the suspected causes, maybe a better way of putting it. The first one I'd like to start with, which is one that I hear on a regular basis from people, I'd say it accounts for maybe probably about 50% of people think that they have a chemical imbalance. Mm-hmm. And quite often they've been told by the GP that they have a chemical imbalance in the brain, which is causing the depression, and it needs to be fixed. Yeah,
I think I will be pedantic here, but not against you. It's against, I think there's a category error there when you're talking about that, because yes, it is absolutely so that when people have symptoms of feeling very depressed, then the biochemistry is different, and that they have less serotonin floating around and possibly less noradrenaline and stuff like that. So yes, so it is true that persistent low mood is associated with a biochemical profile that's different from persistent cheerful mood. But that's an association. It's not a cause.
Yeah, to me that sounds like people are getting cause and effect mixed up.
They are,
if you like.
Exactly. Yeah, that's exactly the problem. Yeah, and then if you do a CT, or I wouldn't much use, but a functioning MRI scan, and you show that there are differences in people's brain patterns when they're very depressed and when they're not. Again, it's a false assumption to assume that because you can show the chemistry or you can show the physiological changes that's the cause.
Okay.
Whereas it's, I think a more accurate way is to saying that is that's simply a different representation. It's a chemical or a physiological representation of what somebody is experiencing. It's one of the arguments from cognitive psychology that if you change people's thinking patterns, that then changes their mood, which then changes their biochemistry. So that sounds like a causal thing as well, but it's not necessarily. That those might also just be associations, but starting from different directions.
So, I mean, I don't know if this sounds like if we're going down conspiracy theory territory, but one of the discussions that tends to crop up a lot is with regards to the chemical imbalance idea, is that it was like a marketing scheme by pharmaceutical companies to kind of sell people on the idea that it's the cause of the depression. So the same way that, just one day you wake up and you start developing cancer, one day cells start reproducing malignantly. Is that the right word?
That sounds fine, yeah.
That the same thing happens with depression, that you wake up one day and suddenly the brain chemicals just start shifting. This results in depression, and then you need medication in order to fix that. Is that pure conspiracy, or is there any truth to that idea at all, do you think?
Well, I think it certainly isn't pure conspiracy. I'd answer it in a slightly different way, I think. I think, well, in two ways. One is, yes, of course, the pharmaceutical industries do that, but that's what their job is. So we shouldn't blame them for it. I mean, they're wanting to sell their product, and therefore that they want to enable us all to see the world in a particular way that fits with their product. So that's fine. That's what they do, and that's their job. But I mean, there are many other sides to that. There's doctors and other health professionals who, for various reasons, which we can go into, are happy to pursue that. And there's also lots of patients who are happy to accept that. So I think you can't just blame the drug companies for doing what their job is to do. It's something we're all equally responsible or equally culpable, if you want to use that phrase, for that. But then the second point is that, which is sort of slightly more sympathetic to the sort of pharmaceutical perspective, is whether biochemistry started it all off or not. Yeah. If I do have a biochemical imbalance which is related to how I'm feeling, and if some pharmaceutical products will help to shift that balance, and a result of which I then feel better. Well, that's so. Regardless of causation, if we've actually got a situation where, as I do, if I go running and my right knee gets sore because I've been running a bit too far or fast or jerking around too much, I know exactly what the cause of that is. It's me running too fast and spraining my knee. But actually, if I take some ibuprofen, that actually helps my knee to get better, because it reduces the inflammation and gives me some pain relief. So I don't have to have a particular view of the cause in order to think that a particular drug might or might not be helpful. That's not to say that I think drugs are the main or even the primary answer for people with depressive symptoms, but there's a perfectly reasonable argument why you could use them. Yeah,
I'm gonna dig into the antidepressant stuff a little later. Second common one is this idea of predisposition. Yeah. So on a genetic basis, if you like. So this idea that people kind of would articulate as, my mother had depression. Yeah. Therefore, I'm predisposed to it because there's a genetic component there. Okay. So again, any truth to that? And
possibly, with the specific statement you make, my mother had it, and therefore I've got it, and I'm genetically disposed. There's obviously there's a logical flaw there as well, because the fact that my mother had it and I have it, that could be because of some genes, or it could simply be because of the environment. If my mother was depressed all of her life, then when I was growing up, I'm just much more likely. I'm in that environment. I'm much more likely to become depressed. In the same way, I mean, there's a stricter argument about sort of studies have looked at twin studies where you've looked at monozygotic twins where they come from the same egg, and dizygotic twins where they come from different eggs. You get slightly different likelihoods of both being depressed in those circumstances. I mean, those are a bit more compelling, but even so, I mean, you could still talk about sort of sharing an intrauterine environment. So
what about this I don't know anything about this at all. I just kind of skim over it. The 5-HTT gene.
Yeah. Yes. I mean that's a very interesting one. There's a huge amount of research funded by pharmaceutical industries, but by lots of other people as well. And I mean that's a gene which has been shown. It was shown initially in a study in New Zealand, but shown also elsewhere. To if you've got one particular version of that gene, you're more likely to respond to negative life events by becoming depressed. Whereas if you've got a different version of that gene, you're less likely to respond to those. So that's interesting.
So again, but I think what's important to kind of point out there is that that's not saying that because you've got this. You've got this gene or you haven't, or there's a lack of it, or
it's two different versions of it.
Okay, so if you've got one version of this gene, that doesn't mean that you are guaranteed to get depressed, that depression is going to pop up out of the blue and come and
absolutely
not.
No. This particular study suggests if you've got one version of the gene, if life gets difficult, you're more likely to get depressed than if you've got the other version.
Right, so
you're just a bit more likely, but it's also it's not that particular gene. It's not just related to depression. It's related to a whole variety of sort of mental health problems. So it's not as it's nothing like a specific. And also, more recently, people have found lots of other genes that they reckon are more likely to trigger depressive episodes than other ones. So it's as with most of this stuff, it's a lot messier than it looks at first glance.
And kind of very early days in research as well.
Yes. But as I said, there's been a huge amount of money thrown at this particular question, and I have to say the amount of evidence that's emerged from it is not very compelling. Yeah. So there's a bit. Yeah. I'm not throwing it out, but it's not huge, and it's not hugely compelling either.
Okay, so genetics, I think, kind of brings us nicely onto the evolutionary kind of aspect of depression. Now, my understanding is that some people think that depression is an adaptive response, which sounds very bizarre. Like how does depression help you survive and replicate? If you like,
I think this is where it starts to get interesting, really, because I think because so far we've been talking about depression as a problem.
Yeah. And
clearly, if you're feeling, no energy and no mood and wondering whether life's worth living, I mean that doesn't sound like a barrel of laughs, really, and it isn't. But there's a whole variety of sort of takes on this. So one of the common ones, from an evolutionary point of view, is about sort of it's about hierarchies and about dominance and submission. And I'll give you two. So this is one about dominance and submission. So if you're in a situation where you actually haven't got very much power, and you really haven't, it's actually better. You're more likely to survive and reproduce and do all those things if you adapt to a rather more submissive, passive, low-key view of the world.
Okay.
Than if you go bouncing around saying I'm the king of the heap when you're not.
This sounds to be a bit of a. I don't know if I'm missing something, but it seems like a bit of a disconnect there because on the one hand it seems that would make somebody more, if there was a genetic component, an evolutionary component there to do with hierarchy, that would make somebody introverted but not necessarily depressed.
Sure. Yeah. I think that's a very fair point, and but I think this partly goes back to sort of the breadth and the messiness of the definitions.
Okay.
But no, I think that's a fair point. It's not quite the same thing, but it sort of it fits with it. The other one that I think certainly works for me, and I use it quite a lot in my clinical practice, is in relation to concepts of hibernation. So that if life is very difficult, objectively, like if you're a polar bear or a squirrel and winter's coming and there's not going to be any food around, and you just to become depressed for a while, to withdraw, to sort of to shut everything down is a way to survive. So in the same way, if this is the sort of parallels I use, so if somebody's life is just the sort of whether they're having awful problems at home, abuse, or just whatever's going on outside is unspeakably difficult, and actually to withdraw, to shut down, to shut everything down, and just sort of get down to a very basic thing and plod through until life gets better, actually is it's an excellent survival strategy.
Well, that kind of ties in with the idea that a lot of depression kind of gets better by itself after a certain amount of time, doesn't it? Do we not know the percentages on that, or?
Yeah. Well, again, it's with all these things, it's different studies in different circumstances. Most of the early studies have been done in psychiatric hospitals or in mental health centres or outpatient clinics, obviously, where you get, by definition, people who have more serious problems. So in those groups, then you're a relatively small proportion of people who get better. I mean, it's roughly, I can't remember off the top of my head what those numbers are. But in the more general populations, in the general population, or in people who come and see family doctors, it's a much bigger proportion of people who will actually get better spontaneously, or because life changes, or because they've worked out some different ways of doing things.
Yeah, I suppose because one of the big components of depression is the idea of rumination. Yeah. Which, I mean, do you think that ties into the idea that if somebody's going through a difficult period in their life, then if the body or the mind gets into that rumination mode, that helps people figure things out and. Well, it doesn't. I mean, it might do. I mean, this is one of the things. A lot of things, like the hibernation thing, it works to an extent. But if it keeps on going when the when springs come, when the external threat's gone, then it actually changes from being something beneficial to actually being something that gets in the way. So that's sometimes where you need some outside help. But so rumination the same way. To a certain extent, it might be helping you to figure stuff out. But if it just goes on and on and on, and you're going round and round in circles, then it then becomes part of the problem eventually. I think the idea of the hibernation idea, actually, a nice little segue into what's probably the main cause of depression is life circumstance. And I'm just wondering if you think that's, do you subscribe to that as being maybe the main cause of depression? And yes, it's a simple answer. So if we're keeping the word depression as a thing going in the conversation, even though we're a bit sort of, we have to, I think, just to keep it.
But referring back to our previous uncertainties about it.
Bearing that in mind.
Yes. I think for most people, most of the time, developing symptoms of depression, feeling depressed is usually related to difficulties in life circumstances, which might be a combination of things that have happened in the past that have been in childhood or a while ago that are very hard to come to terms with, or things that are happening right at the moment, or things that you're anticipating happening in the near future.
But do you think that that would be the kind of the main driver, if you like, and then all the other, like the genetic component and the evolutionary component, kind of secondary?
Yes. So they come into play. Yes. So to the extent there might be some genetic factors that make you more or less likely to react, or evolutionary ones, I think that they don't come into play here. I mean, I think the evolutionary ones are ones where they're giving you different models for understanding what might be happening at the moment, right? Rather than actually being directly coming into play, I think.
Well, one of the interesting things that I did read in your book, which struck me, I hadn't noticed this in my own interactions with people that are struggling with depression, was that people fail to kind of separate their emotions from the life events. So when you ask somebody how they're feeling, they'll immediately begin to tell you
about their life,
the life events, and it's quite an interesting distinction. It's one I hadn't noticed until I read it. Yeah. But like I say, when I'm talking to people at the mental health support group,
did you observe that as well when you do that?
Only since reading it, looking back on it as well, it's like, wow, when you ask somebody how they're feeling, the introduction will be, "Oh, I'm not feeling too good," and then straight into,
and it's because blah 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 blah. Yes.
I found that a fascinating idea. Yeah. Okay, one thing. I don't know how you're going to feel about this bit as a GP, kind of defending the.
That's okay. I'm very happy to defend or not
the profession.
Or not. Yeah.
So, So somebody's feeling down, they feel like they may have depression. The first port of call is to go visit the family doctor.
Yeah.
I hear 3 main accusations thrown at the family doctor.
And throw them at me and I'll see how we do, yes, yeah.
And I'm just wondering what you think about the validity of these accusations, and if there is any truth to them, what to do about it, if you like. Yeah. So I'll run through them quickly and then we'll take them one at a time. Yeah. So the first one is doctors don't know what they're talking about. Uh-huh. The implication being that doctors aren't trained adequately in mental health care. Yeah. The second would be that doctors just fob you off with pills. I hear that one a lot. Yeah. Again, the implication being that doctors are kind of just drug peddlers for the pharmaceutical industry. Okay. Yeah. And thirdly, I hear this quite commonly. He doesn't care. Doctor doesn't care. Yeah. I've told him about my problem. He's not bothered. Yeah. I can tell he's not bothered. Yeah. So going through those one at a time.
Yeah, well, I'd say broadly we're guilty on all three fronts, really.
Oh, wow. Okay, yes, interesting. Yes, okay, yes. So take the first one then. So doctors don't know what they're talking about when it comes to mental health. So. Yes.
Yeah, and I mean that's objectively true. In if you're talking about family doctors, obviously psychiatrists would be different. If you're talking about family doctors, GPs, most GPs haven't had training in psychiatry or in mental health as part of their training to be a GP. They have a bit as when they're medical students, maybe a few weeks as a placement, but most don't have. A lot of people do, but the majority of people haven't had a psychiatric or a mental health placement as part of their GP training. So they've had to sort of pick it up as they go along.
Is that still true today mental health's it's on the agenda?
Yes.
Yes. But is that still true of doctors training even now?
Yeah. Because when you're trained to be a GP, you do, obviously you spend time in general practice, but you also spend time in casualty, in doing obstetrics and gynecology, doing medicine or doing whatever. And obviously some people will do a mental health placement within that, but most people don't. But I mean, it's not quite as bad as that, because as part of your general GP training, you learn a lot about sort of general communication skills and general interaction skills, and those are, I think, actually very important basic building blocks for good mental health care, which we might come back to later. But it is objectively the case that most GPs have not had formal mental health training beyond what they learnt as a medical student.
Do you think that's a mistake, or do you not think it's maybe the doctor's domain?
Well, mistake isn't quite the right word. I think it's a problem because mental health problems are very, very commonly presented in primary care settings in a variety of different ways. And so if people haven't had the relevant training, then obviously they're not in a position to deal with them as well as they might otherwise be.
Do you think, though, I mean, is it still the case that GP appointments are limited to like 10 minutes? Is it?
There's a move towards 15 minutes, but generally speaking, it is, yes.
See, the problem with that is, even though it might be a problem that doctors aren't trained in mental health, 15 minutes is not really enough time to deal with it adequately, or is it? Is that, am I making a false assumption there, or?
I think it's obviously if you have a lot of experience and training, it's possible to do quite a lot in 15 minutes. But yes, 10 minutes or 15 minutes isn't very long, but you can come back and see the doctor, which is what I very commonly do. If somebody I'm meeting for the first time and they've obviously got some mental problems, we'll start the conversation and say, look, this is really important. I need to see you again, depending on how serious it is, in a few days, in a week, in a couple of weeks' time, and we'll continue the conversation. So over 2 or 3 or maybe 4 consultations, where it's, you've got an hour. Over that time, you can, if you want to, you can do very thorough assessment and have some quite detailed conversations about what's going on.
Well, I suppose the obvious other argument is that 10 minutes with a doctor who is trained in mental health care is better than nothing at all.
It is. Yes.
Okay, so
that was your first challenge. Yes.
Second one, doctors just fob you off with pills. Okay. So doctors are just there to peddle drugs for the pharmaceutical industry.
Yes. Well, again, there's a lot of truth in that. I mean, it partly fits with what you were just talking about sort of having very brief consultations and feeling that you need to. I'll put a slightly more positive spin on it than you get. The feeling that you've got a patient in front of you who's clearly in distress and they need some help. And what can you do in 10 minutes? One of the things you can do is hopefully listen sympathetically. But then a lot of people think, well, the main other thing I can do is actually give them a prescription. And there's been some quite interesting research done in Scotland, actually, where doctors give a patient a prescription for some antidepressants, knowing that it's not really the answer, because the doctors know as well. The doctors aren't stupid; they know as well it's the patient's life circumstances. But they're actually doing it not because they're in the pay of the pharmaceutical industries, but because they think, well, I actually want to show this patient that I care. And so I want to demonstrate by something practical that I'm hearing what they're saying, and I want to offer some help, however helpful it'll be. And so here's a prescription. Your listeners may cackle uproariously at that, but there's an element of that in some consultations. But also, I mean, nowadays, I mean, we don't just have to do a prescription. We can refer for psychological therapies of one sort or another, although the waiting lists for those are huge. So that's not necessarily as helpful as it might sound.
Well, we've already gotten to work on the third accusation,
which is my doctor doesn't care.
Yeah, he doesn't care. I hear that all the time. He's not bothered.
I mean, do they usually say he doesn't care or she doesn't care? Because there might be a difference.
Oh, well, that's probably just me being...
Well, no, but it mightn't be, because I think there might be something about women GPs being a bit more empathetic or whatever. I don't know. But that was just one thought. But yeah, sure. But I think, I mean, it's a big thing, isn't it? And
the thing I read in your book was this idea that kind of doctors are more used to dealing with disease, lesions in the body, if you like, symptoms that present themselves that haven't got an emotional component to them. Yes. And that not only are doctors, I suppose because doctors aren't trained in mental health care, the idea of dealing with a patient on an emotional level is going to be tricky. Yeah. But also, I suppose you have to sympathise with the doctor in that you can't get emotionally. It's no good having two emotional people in there. No. Obviously, if you're both sitting in tears together, that's not necessarily very helpful. Yeah. I think that those are really interesting thoughts. And they also have to add into that how many patients is the doctor seeing in the morning surgery, and then their visits, and then the afternoon surgery. So there's a limit to the amount of caring that can be. Yeah, of course. It can be displayed. So, I mean, that's part of it. I also think, although GPs, as I mentioned a few minutes ago, are trained quite well in communication skills, and not all patients would think that was so, but that is generally so. Those communication skills tend, in fact, to focus on, as you're indicating, on cognitive aspects. Rather than on emotional aspects. So we're taught to ask about patients' ideas and of what their problem might be, their concerns about what else is going on, and their expectations for treatment. Yeah. So we're talking, and probably most GPs do get around to asking some of those bits most times, but none of those actually apply to some. Not taught to ask how people are feeling about stuff. Yeah, so it comes back to training, I guess. I think that's my bottom line. I think yes, some people are rubbish and some people are great, whatever. But I think there's a systematic problem in the GPs don't have sufficient training in the emotional affective elements of the concept, which are hugely important, but also difficult. So it's not that doctors don't care, it's that doctors don't know how to show that they care. Let's go with that. That would be I think for most people that would be a much fairer conclusion. Okay. Yes. Thank you for that. Yes. Yeah. Yes. Yeah. So another concept, I'd never heard of this until I read your book. Yeah. This idea of iatrogenesis. Yeah. we explain what that is exactly first before we kind of delve into it?
Well, I mean, that refers to the idea of doctors or the medical profession actually creating disease or creating illness.
Inadvertently, I'm assuming.
Hopefully, yes. Let's assume inadvertently in the huge majority of cases, yes.
So how would that concept manifest in the case of depression?
Okay. Well, I mean, if I start elsewhere, I mean, it's most commonly seen with unwanted or the unexpected side effects of medication that's given, or so somebody's got arthritis, and so you give them some non-steroidal anti-inflammatories, and then they get a stomach ulcer. So that's a iatrogenic effect, which you clearly didn't intend to do, but that's an effect. So I mean that's the simplest version. But if you apply it to sort of people who are feeling low and down and miserable with life. If I'm feeling like that, and then I come and see my doctor, and he or she sort of thinks about it and says, "Oh well, Chris, I can tell you the problem is you're suffering from a depressive disorder." I might have a number of different reactions to that. I might think, "Oh, thank goodness, I've got a disease, and I can relax, and I'm going to be treated."
Okay.
I might think, "Oh goodness me, there's something seriously wrong with me. I'm a diseased person," and then I might start to behave in different ways. I might start to behave like a patient rather than a human being, and I might expect other people to put me in a category of someone with a serious or perhaps just with a disease. I might then sort of take on the characteristics of an ill person as a result of my doctor telling me that I've got a depressive disorder.
Right.
Whereas if the doctor says to me, "I can see your life's really, really tough at the moment, and if I was in your situation, I don't know how I'd be surviving either, but let's think together about how we're going to do something about it." I'm not going to go away feeling, well, I don't know, but I'm less likely to go away feeling I'm a diseased, a subnormal, a sub-human being. I'm exaggerating it, but that's sort of broadly how the argument runs.
But interestingly, you talk about how that can then extend beyond the patient to the people around them. So even the doctor will start to see that my patient is a person who has depression.
Yes.
And then family and friends.
Yes.
And because those people then start to treat that person as a depressed person,
then they become more likely to behave that way. Yes,
and it perpetuates.
Yes, it becomes a role in life. Yes, and that's that. I'm not saying it is always, but that can become a problem. Yeah.
Is that? Do you think that it's worth? I mean, for me, my initial reaction to hearing that is that when a patient's talking to a doctor or getting any kind of diagnosis, that they should be made aware of that phenomenon, because then it might work to undermine the effects of it, if you like, because it's only by being aware of it that you might be able to avoid it and kind of take a step back and have a bit of perspective and say, okay, well, I'm not gonna. So maybe I've got depression or whatever. But I'm not now going to take that on as a role, and I'm going to be aware of it affecting the people around me. And I mean, is there any truth in that, or am I just getting a bit too hopeful there?
You're absolutely right, but I think that's very tricky to do. I don't know how I would advise you or other people. I mean, yes, you're right. It requires a lot of thinking through at different levels. So I've been given this diagnosis of depressive disorder, and I can see, while I'm feeling this bad, that's quite a useful role for me to adopt, and it'll protect me from problems in work, and the family will back off, and whatever. But then, I promise myself when I'm feeling better, I'll come out of it again. It's yes, that's absolutely the right approach, but it's quite hard to do.
It's just I just noticed,
and I mean that's partly going back to what I was saying. That's why I prefer verbs and adjectives rather than nouns. So that's why I prefer to talk about it. If I use the D word at all, I would talk about feeling depressed or finding life depressing, because it's still keeping you as you, with whatever's going on around you.
It was just when I read about that concept, and I kind of looked back over. I mean, my big thing was, I became an agoraphobic. I had agoraphobia.
Yeah.
But it was only when I read about this idea of iatrogenesis that, in hindsight, I looked back and realised that there was a point when I started to attach that title to myself.
Yeah.
And then it seems to be that after that after that diagnosis came, if you like, it got worse.
Yes.
And the more I researched it, the more I found out about I almost sought out the symptoms and the situations that would.
It's really because I don't. I mean, going off the tangent, but it's the same thing. I mean, I'm very comfortable and hugely value sort of the whole business about expert patients in different conditions, not everything in mental health. But there's a downside of that, which is that if you're an expert patient in agoraphobia, then you sort of have to live your life as an agoraphobic.
Yeah.
Whereas if you're an expert patient in, diabetes, you have to live your life as a diabetic. And but there's so much more of you than that particular bit. Yeah. And I don't know what the answer is, but like many things, there's a tension, there's a balance. But we have to try and we don't always get it right, but we have to try and get it right.
Yeah, my recommendation to the listeners would just be to kind of I don't know if they've been going through any kind of mental health issue for kind of a significant period, to just kind of bear that in mind and see whether that's kind of had any effect. They feel that's had any effect on them. So.
It's worth putting in there just for people to think about. Yeah.
Okay, so I'd like to move on to the treatment aspects of it now. Yeah. Probably the most important element of this discussion. So let's start off with medication, antidepressant medication. Yeah. So there's different types.
Yeah. Yeah.
We've got SSRIs, which are
selective serotonin reuptake inhibitors.
Yeah, and then SNRIs,
which are selective noradrenergic reuptake inhibitors, which are sort of a slightly more modern version. Yes.
Yeah, and then we've got tricyclics. And monoamine oxidase inhibitors.
Yeah, nobody ever takes the last ones anymore.
Oh, okay.
Yes, yeah. So it's usually SSRIs or SNRIs and tricyclics are the main ones that are around.
Is it possible to kind of give a brief overview of what those three actually do, or what it's hypothesized that they do?
Well, they all have effects on your neurobiochemistry. The tricyclics have a rather broader effect, but they work particularly in relation to a neurochemical called acetylcholine. SSRIs work with serotonin, and the SNRIs work with things like noradrenaline, and the hypothesis is that they change the biochemical balance in your brain of those various chemicals, which lead to changes in mood. They also each have different effects and side effects as well. But
so, I mean, just out of interest, why would somebody be prescribed one versus the other if they're all meant for treating depression?
Okay, well, I mean,
because each one seems to focus on a completely different chemical element.
Yeah.
So.
Is
it completely arbitrary? Is it just
no?
Okay.
No. I will defend these drug therapy to a fair extent. No, it's not arbitrary. No, okay. I mean, very, very broadly, the tricyclics are the ones that have been around for the longest, and if somebody is depressed and also very anxious and they're not sleeping very well, then as long as they haven't got heart disease or they're not very old, then I might well think a tricyclic would be quite a good thing, because it has quite strong sedative side effects.
Yeah.
And SNRI or an SSRI broadly they're more similar to each other. Tricyclics are a little bit more different. I'd be more inclined to prescribe those for someone with depressive symptoms who isn't quite so anxious and who doesn't need sedation. If somebody's got a mixture of depression and pain, which is quite common, then either a tricyclic or one of the SNRIs might be quite a good. So and I'm just giving a very simple overview. So there is a method to it, though. Yeah, there is an underlying method to it, and obviously within those groups there are, with the SSRIs, there are lots of different ones. Prozac, fluoxetine was the first one. Then you've got paroxetine and sertraline and citalopram and various other ones, and each of those has a slightly different effect profile and slightly different side effect profile, and that there have been some very good meta-analyses of thousands and thousands of drug trials, and the one that I tend to follow is one that was produced in 2009 by Cipriani and colleagues they're looking at SSRIs in particular, and they reckon that in terms of cost and benefit and side effect profile, then either sertraline or possibly escitalopram or citalopram are the drugs of choice.
Okay, so I did want to get onto that, the kind of the efficacy of antidepressant drugs, because that's not. I recall you saying that it's not clinically significant, that the difference between antidepressant and placebo.
Well, it depends, and again, we're getting into an absolute minefield here.
Okay, is there any way of
So I mean, there's huge controversy, because obviously, this certainly is an area where the pharmaceutical industry wants to defend itself.
Yeah.
So and they do so very, very vigorously, although they don't always publish all of their data, so you have to be a little bit careful about that.
Publication bias.
Yes, it's less than it was, but it's still around.
Yeah.
But the study that I find the most useful is one by Irving Kirsch and colleagues a few years ago, where they did another huge meta-analysis where what they found was that at mild levels of depression, there's no difference between placebo and an active drug.
Okay, interesting.
At moderate levels, there's a bit of a difference, but it's really only at very severe levels of depression. It's really absolutely at the severe end of the spectrum that there's a clear and incontrovertible difference between an active drug and a placebo.
Okay.
Now, that's been challenged. There have been recent studies. I won't go into the technical details. Basically, what they're saying is that the trouble with that is that that's looking at groups of patients, whereas if the other people have done studies where they've looked at individual patients, and then they reckon that there is evidence of benefit at lower levels, but I'm not sure about that. So,
what would your conclusion be? What do you think?
I think actually the current NICE guidelines are not a million miles off the mark. But where basically what they're saying is if people have got mild symptoms, then you want to look at non-drug options. Yeah. If they've got moderate symptoms, then you could consider drugs alongside other psychological or social options. But if somebody's got very severe depression, then probably you should be thinking of an antidepressant as the first thing to think about.
Okay, so speaking of therapies, rather than go through like an exhaustive list of the amount of different types of therapies that are available, what seems to be the most effective? If someone's going to be seeking going the self-help route, if you like, not the fully self-help route with doing it at home with books, but seeing a therapist, what's the best school of thought, if you like, the most kind of effective?
It's a great question. I would like to give you a very simple answer, but it isn't that simple.
Because CBT seems to be the kind of the predominant one at the moment.
It does seem to be that, and there's certainly evidence for it. But it's also it's the most researched. It's had the most financial backing. It's a bit like the pharmaceutical industry. There's been a lot of money, and a lot of science. A lot of stuff has been pushed into CBT. Mm-hmm. So therefore, it's not surprising that you get more noise about it. It's fine for lots of people, but not necessarily for everybody. So I mean, it works for people who prefer a sort of cognitive, sort of intellectual approach to things. It doesn't work so well for people who have different sorts of approaches. So I mean, that's what I was going to say. I think one of the main things is to you as a patient or me as a doctor to sit and talk about what the particular patient, the particular person thinks about things that might well be helpful for them, because in a way there's such a large variety of things. What the patient's view is about things that might be helpful is hugely important.
Yeah.
Obviously, there's some things that I might say, well, actually, I don't agree with that. But generally speaking, if somebody is thinking, let's talk with somebody who's got symptoms of moderate to severe depression. If they're thinking, well, actually, doc, last time I saw you a couple of years ago, and you gave me that particular antidepressant, and I felt better from it, I'll say, okay, well, let's go with that again. But if they say, well, actually, I really would like to try some CBT because I've heard good things, I'll say, let's go for that. Or if they say, well, really, I've been thinking about sort of getting back in the gym, or sort of doing a park run on a Saturday morning. Yeah, let's go for that. So as long as it's not something that I think is just dangerous or completely wacky, I'd be inclined to go with that. But for two reasons: one, because all of those things I've just described, there is an evidence base for them, or mindfulness is the other one. But also a lot of it is, I'm using placebo in a positive sense. So if you believe something is going to work, then it's much more likely to work.
Yes.
That's not in any sort of cynical sense. That's just a genuine statement. So somebody, if I think really CBT is the thing for you, and you think, oh, for God's sake, I'm never going to go, it's not going to work, is it? It's the double thing. It's something that genuinely would work, plus you thinking, yeah, I want to have a go at that. But it's both of those things that are actually then you get the best benefit.
Right. Okay. So, in closing, and all these things considered, what's the prognosis for people with depression? And again, we're bearing in mind that that definition of depression is very wide. What is the...
Well, I think it's very good for pretty well everybody. Again, we were talking earlier on about depression, and you talking about comparison with cancers. I mean, it's not the same thing, because your cancer, once you've got a cancer, it doesn't sort of change its mind and go away again. It goes on, it develops. So depression isn't like that.
Well, you can take control of it.
You can, and even if you don't feel you can, with most people, life gets better. Spring comes, and there are opportunities for fresh starts, which occur. So I think, generally speaking, I love talking with people about depression or feeling depressed or life being depressing, because I'm hugely confident that there are things that they can do, I can do, and certainly we can do together to actually make life much better. Not in the next couple of days, but over the next few months.
Yeah, definitely an important thing for people to consider, because hopelessness is one of the kind of elements of depression.
Of course it is, yes, yeah.
And just being able to recognize that even if you don't actually do anything, life is, the circumstances of your life are going to change around you regardless.
Yeah.
And that if you take any kind of control over that change, that should feel empowering.
Absolutely right. Yeah. I'm glad you used the word hope. We should have used it earlier, shouldn't we? Part of my job as a doctor is to hold on to somebody's hope for a while until I can give it back to them. But in any event, just begin to think with them about how hope can start to expand.
Well, I think hope is a perfect note to end this interview on.
Yeah.
Chris Dowrick, thank you very much.
Thank you very much indeed.
If you'd like to comment on this episode, or just find out more about some of the topics we covered, you can find all the show notes and relevant links if you go to myownworstenemy.org/podcast. If you'd like to drop me a message, you can find me on all the various social medias at Danny D. Whitaker with 2 T's. I'll see you again next time.